the use. That's the sound. And also just another disclaimer, which you won't worry about too much, but should you not wish to have your camera on the recording or imagery, please feel free to turn it off now. My name is Neil. I'm a therapy development manager for the UK and Ireland, and I'm helping out a bit in the Nordics with a few things. We've been asked today to just give an overview of SIRT, selective internal radiation therapy with TheraSphere, and what it can possibly mean for your practice. So we've slightly adjusted the agenda. The basic plan is I'm just going to do 10, 15 minutes just to run through the procedure, where we're at and what Boston is. You will probably be familiar with the company itself. It's quite a big one with a lot of products and a lot of divisions and a lot of staff members. So you may have met some of my colleagues in various guises in your hospital. We'll then hand over to Rob White from our Health Economic Market Access team, who will do a short presentation, just an overview of the cost effectiveness data around this therapy area. And then we'll hand on to Dr. Peter Littler, who's an interventional radiologist from the northeast of England, our biggest TheraSphere using site in the UK, who will talk about patient selection, a bit on how data has developed over the past 10 years, and really how their practice has grown and evolved over that space of time. Let me just get my slide to move. Brilliant. So I'll just start very briefly now with where we're at. We are celebrating later this year 20 years of European-wide approval for TheraSphere with HCC. So that will be a big piece that you will hear us talking about over the coming months. Really, as it says on this slide here, it was 1999 that it started over in the US with some approval. And the key thing here, rather than understanding at this point what any of the data means, is just to show the evolution of it. We have really moved from what started off as a palliative therapy to a primarily curative setting. There are still plenty of palliative patients we can help, but really now we have refined and sort of figured out that with the right patient selection and the right treatment techniques, we can move to getting the patient to a curative, whether that's resection, lobectomy, transplant, those sort of things. The key bit, you'll see a lot of the data has come really from 2018, 2019 onwards, and that was really the evolution of dosimetry in this therapy area, and really refining and personalizing to the disease state your patient has what we can do and how we can help them. This book, which Dr. Littler will reference and discuss later on, you will come to use in your clinical practice every time you're planning a patient, really. I would imagine Dr. Littler still refers to it, should they need to. And it's the clinical and dosimetric considerations for Y90 with glass TheraSphere. This has been built up over the past 5 years and reviewed on multiple occasions to really show you in the clinical scenarios from when your patient comes to the MDT, what the possibilities are and what you can do for them. It really has shown over time that when we're not saying we want every patient that has HCC that comes through, like every treatment modality you have, there are options where this is a good treatment option for it, and there are patients where unfortunately this is not going to be the beneficial thing that we want to do. So this, almost our guidance and our Bible, I would almost say, really does guide you through step by step from patient diagnosis and entering the MDT through to post-treatment imaging, the best way to treat them to get the most efficacious outcome in that patient. Just in case anybody on the call who watches this back hasn't been through the procedure before. So it is an identical procedure to what you may do with the resin therapy, although there are big differences in the way the treatments work and the data around them and the dosimetric guidelines. But we would start with a workup of the procedure, which can be done as a day case, as your hepatic angiography, like you would do if you were doing TACE or other intra-arterial therapies. One of the key bits we want when we're looking after SIRT patients is that you use cone beam to identify the diffused volumes and maximize the efficacy of where we're going to treat. This is done, the workup, to determine the lung shunt fraction. Some of these very vascular HCCs, obviously, as you will be aware, can have feeders heading off into other parts of the body. So we want to make sure that the therapy we're going to do is not going to do any harm anywhere else. It's also used this workup to define the treatment strategy, which I'll go through in a few minutes with some imaging. It does involve your nuclear medicine team and getting some technetium labeled MAA into that treatment area and working out the dosimetry from that. So nuclear medicine is my background. I worked with Dr. Little at the Freeman for 10, 12 years performing these patients. So we started with resin and the practice evolved into glass. We use the SPECT CT data, and we have, hopefully you can see that loading up now, some dosimetry software called Simplicity, which we work with and support, which is all about doing the best possible treatment plan for these patients. There are multiple automated tools to help define liver volumes, tumor volumes, necrosis, normal tissue, perfused volumes, all the things that you would like to do. And it really is an excellent tool for what we hope is moving away from what was probably practiced 10 years ago of being very distal in your treatment delivery, getting to the edge of a lobe. And this was the common practice across Europe and the US as well, getting to the edge of the lobe and putting the dose in and letting the vascular uptake take it. And that is still, in some cases, in a very hypervascular tumor, a great way to do this treatment. But now we are much more selective with our dosimetry to maximize what we can do without causing harm. Or, we don't really ever see now cases of RILD, radiation-induced liver disease, because of the dosimetry data and the methods that we use to define what we're doing to these patients. Once we've defined our volumes, it's very important on this software that we register. So in this example, our volumes are taken from a diagnostic CT that will have come in a month or so before the patient workup. And we fuse that imaging and have multiple registration algorithms with our SPECT CT data so that we can take our MAA counts from the SPECT. We then use some of these automated tools that we have to define the regions that we want to treat. It is possible on this to do treatment plans with multiple perfused volumes and multiple feeder points, depending on your vascular anatomy. And what that leads to on the dosimetry page is either with these isodose lines or just multi-compartment technology dosimetry, you can define what treatment levels you want. And whilst we're not going into this in detail today, this patient is actually, I'd say, an older one from our initial revision of the clinical and dosimetric guidelines, because if you look on the right-hand side of that in this table, let's see if my pointer's on, around this area here. So what we did here is we planned to give above 205 gray to this tumor, which was the lower end of our tumor dose recommendations. That's up significantly higher now, whilst keeping an eye on what the perfused volume was going to get, what the normal tissue in that liver was going to get. From that, we can have a look and see what the whole liver normal tissue is, perfused normal tissue, all these values to maximize, again, how we're going to treat this patient and how we're going to tailor their plan and give the best outcomes possible for it. What we would then do after the workup and after we've done that dosimetry is go on to what is the TheraSphere Now platform, which is an online ordering portal where you can put in the desired activity that you wanted on treatment time, and up will pop a lookup table with deviation plus or minus 10% to see what vial you can order to have delivered the day before treatment. As far as the treatment goes, it's quite often an overnight stay. Some cases, depending on your local, so it's radiation protection guidance, it can be put in an isolation room, but most places that isn't mandatory. As it says, it can be a day case, and you will do a post-treatment, depending on your technology, nuclear medicine, SPECT CT or PET CT, to confirm where the dose has gone. As far as complications go with glass TheraSphere, we do get some post-embolization syndrome, but much lower cases of that than there is with the resin equivalent, and that's because of the smaller size of these particles. You're not causing any microembolization or anything like that, so you get much less in this nausea, pain, and fatigue. Very low numbers of cholecystitis infection radiation hepatitis, tiny amounts, and all of these numbers have come down massively over the last 5 years in the advent of modern dosimetry. As far as follow-up goes, it would be usual to do some CT around the 6 weeks, 3 months, and 6 months mark, but you can follow local protocol for that. And the reason we recommend these sort of timelines is basically, as you can see in these images which follow those timelines, it can take the 6 to 9 month mark to fully get the outcome of your treatment. If we do look before that, as long as it's heading in the right direction, we continue a sort of watch and wait policy on it. Why we push for TheraSphere and push for glass? It's the highest specific activity of these treatment types around, meaning you can get more radiation decays per microsphere than with any other product. It's minimally embolic. As I talk about the post-embolization syndrome, this is not something that you really see with this product, and you can be very selective with the delivery of it. Just to let you know what's going on and what support we have should you wish to work with us on this procedure. So you've got the local in-country support. Osa's on the team. She's in one of the sites with you now. Ludwig, the manager, and Tommy, the business development lead. So these are all your local contacts who can help us with any site setup. We have a clinical support team, which is European-wide, basically, and we do a lot of dosimetry support remote via Teams for every site that's starting off, really. We still dial in the UK to sites that are 2-3 years down the line doing so. We still pop up whenever they need advice on a particular patient, so you're never left on your own with it. We have a medical team who can discuss research projects and anything else that you want and disseminate data to your MDTs. As I'll hand over to Rob soon, there's a HEMA team and a market access team who look after our cost effectiveness and can produce budget impact models to show how it will benefit your site. As far as starting sites off goes as well, we also have European-wide support of proctors like Dr. Littler and certain others. We have referring physicians who will talk to MDTs and talk about their experience with the product. We also do preceptorship and centres of excellence round as well. So there is limitless, basically, support for anything you need at any point. Just to finish off, I'm going to touch on where we're heading with TheraSphere and why we're a good company to partner with on this. We're very aware of the advent of immunotherapies, and we have multiple trials ongoing to try and figure out the best regimens and the best timelines to really look for intermediate and advanced stage along the BCLC patients and bring them hopefully down to more likely curative outcomes. We've recently completed the Frontier study, which is a glioblastoma. So we are looking at TheraSphere outside of the liver and other indications we can help in. There's been some good early outcomes in this Frontier study, which was a dose escalation looking at glioblastoma, which is a disease that has very poor outcomes. We're also looking into prostate cancer with it as well. I believe there's a kidney cancer one now going on. So there are multiple ongoing indications outside of the liver that we think we can benefit patients with. On that, I shall finish this part and stop sharing temporarily. If there are any questions, please do jump out at any point and ask them. But failing that, I will move straight on and share again to get set up for Rob's cost effectiveness talk, if that's okay.
Thank you, Neil. While Neil's setting it up, I'll just introduce myself briefly. So I'm Rob White. I work with Amanda Spies from the Health Economic and Market Access team, who covers the Nordic countries and certainly Sweden with Matilda and the team. What I want to try and do today is cover a little bit, as Neil said, on the cost effectiveness of SIRT. So if you want to introduce TheraSphere into your hospital or Glass Y90 into your hospital, we can help you certainly with the business case or with the budget impact model, as Neil said. I want to cover a few topics today. Firstly is economic value, and then I want to really look at TheraSphere and try and really compare it to TACE, because TACE is something, again, that we manufacture in DevTACE, but certainly I want to really try and help you with this idea that SIRT or TheraSphere is more expensive. So why don't we continue using TACE, because we're getting good results? I'm going to hopefully help you with that discussion to show that there's a good place for both of these. So if I could have the next slide, please, Neil, and if you could go on to number 4. First thing I want to do is briefly cover economic value. And economic value is really around what you're willing to pay for something to exchange for a good or service. You think about something you've bought recently. It could be I don't know, a mountain bike or a surfboard, or I don't know what you guys have bought recently, but certainly how much you paid is a lot of dependencies are on that, including how scarce it is it rare? Can you sell it if you want to get your money back? And it's really what you're willing to pay for a service. And that's really important. If I could have the next slide, please, Neil. That's really important for the challenges of today, where budgets are tight. I guess especially since COVID, there's a lot more cost-conscious customers that you have to convince about using something now in a hospital. It's not just like we want to use something, so we're going to use it. There's colleagues that you have to convince as well. So it's really important to show value as well. So I'm going to demonstrate now, if I have the next slide, please, Neil. So in terms of demonstrating economic value, normally we would do that through clinical publications. And if any of you are doing research, particularly into SIRT, I'd really recommend that you put in some health economic endpoints as well with your clinical endpoint. Things such as trying to measure how long a patient stays in hospital or in a high dependency setting makes a huge difference on costs. So clinical publications are one source. The other source is health economic publications. And we've been working with a number of hospitals around Europe, including Dr. Littler's hospital, and we've trying to produce cost effectiveness data to show and demonstrate to health technology assessments agencies in the different countries that certainly Glass Y90 is cost effective. If I could have the next slide, please, Neil, the header. So as I get onto the economic value of TheraSphere, a couple of things about it is that TheraSphere is reimbursed in most European countries now. It's something I know that I've been working on, and colleagues such as Neil have been working on for about 10 years now. And countries such as Germany, Spain, Italy, Turkey are all using, including some recent countries such as South Africa. Now, you're based in Sweden, and Sweden is kind of like the home of health economics. That's how, as health economists, we would look at Sweden. So if I'm going to compare it to other countries that do a proper health technology assessment, such as France or Belgium, then again, those two countries, I think France came on in 2019 and nationally approved the use of TheraSphere for HCC. The UK, so NICE approved it, and again, Dr. Littler's team in Newcastle were very supportive of this in presenting to the NICE committee. That came on in 2021. And then following that, the FDA in the States approved it. And that really changed the European guidelines. And the European guidelines, as I'm sure Dr. Littler will mention, now include, certainly include SIRT. So that's kind of like the progress. And if you look at SIRT, as I mentioned at the start of this, versus TACE, you can certainly see from the number of publications now, and I've picked out a few here, showing that SIRT is more cost effective than TACE. And that's really due to the lower number of treatments. And the publications there I've got from 2015 all the way through to 2024. If I could have the next slide, please, Neil. And here's a couple of papers. Both of those are showing in the purple, if you look at the graph, that SIRT, or sometimes it's called in Europe transarterial radioembolization, means a lot fewer visits for patients. Hence, this is where we're seeing a lot of the differences in costs, and a reason why you can show that SIRT is comparable and certainly cost effective compared to TACE. Could I have the next slide, please? Yeah, thank you. So this is a study that was presented and put together by Professor Mannis. Professor Mannis was based at Newcastle Hospital with Dr. Littler and colleagues, and he did a cost effectiveness study, and this was used in the NICE presentation that we gave to the committee. And if you look at the graph on the left, it's basically showing in purple that on paper, SIRT or TheraSphere looks more expensive than CTACE, DebTACE, or TAE. And so if you've got administrators in your hospitals, the first thing they're going to say is, sorry, it's too expensive. Let's stick with what we're using. But then you have to take into account the middle graph, which is around quality adjusted life years over 20 years. It's showing that there is an improvement by TheraSphere compared to TACE and DebTACE. And if you look at the far right, into figures that I guess the budget holders may understand more in your hospital, you've got nearly a 50% increase in survival with TheraSphere compared to the others. And something very important, particularly for early stage patients. So if you're going to use it around BCLC, A certainly, and B patients, then what Professor Mannis showed again from the study was 86% of patients were downstage. So that is offering them either via transplant or resection the opportunity for a cure, which I think as a patient is really important. This is another study. It's an American study. It's really copied what Professor Mannis did, and it's showing essentially the same thing. It came out last year. They've basically repeated what Professor Mannis did. And again, they showed similar types of results for both TheraSphere and for TACE. This is a study that was done in Italy. It was done in a health economic institute there, and it was done from a piece of work called the TheraSphere study. The TheraSphere study is really showing, as Neil said, how the medicine has moved on and how dosimetry has really changed and been seen by a lot of doctors as a game changer in this area, as they're starting to give higher doses now of radiation. And this study really showed, again, the effectiveness of that. And if you look at the left, you've got in purple personalized dosimetry, being again slightly more costly than standardized dosimetry. But again, if you look at the middle graph and the right graph, you'll see a much better effectiveness in terms of life years gained, and the quality adjusted life years is much higher. And again, if you look at the far right, personalized dosimetry showing a lot less adverse events. And that's really important for obviously cancer patients, and an enormous more number of patients downstaged using personalized dosimetry. So I'm sure Dr. Littler again will cover this, in more detail. This is a recent paper, and it came out about a month ago, and it's from the US. It's from a group of hospitals there. They've produced a consensus paper, and it's showing similar types of things to what I've been saying. This is for radiation segmentectomy, for early HCC. They're really saying it's a really good option for a cure. And there's a number of things down there, and I'll pick out a few. You can see reduced local recurrence rates, a lot less with SIRT and glass Y90 than TACE. And you've certainly got comparable or better overall survival. So all of these things are important if you're going to justify bringing this into your hospital. Can I have the next slide, please, Neil? We mentioned at the start we can help you with a budget impact analysis. If it's something that if you've got to build a business case, or you've got to build a model to show to your colleagues in the hospital over a certain period of time, say 3 to 5 years, this is what the service is. We're currently using this, and this is the advantage that we're going to demonstrate in terms of outcomes and costs for patients and for the hospital. And this is the kind of scenario or output that you'd get from it. If you look at the very top, it's showing over 5 years. And I think we put in about, I think it was 40 patients into this, a small increase cost per patient of about £200 per patient. And this is used in the UK, offers the potential in terms of outcomes of 3 additional transplants. So it's about weighing up, do we pay slightly more and we're getting out better outcomes for patients? And this is what the model can help you with. Can I have the next slide, please, Neil? Just really the final slide before we hand over to Dr. Littler is that there is a load of evidence now showing certainly that TheraSphere Y90 is backed by good evidence. It's showing some better patient outcomes and is cost effectiveness, certainly versus TACE. And the final thing I'd say is that point around personalized dosimetry is really level 1 evidence that we've got there, and that's been produced and is showing much better results than standardized dosimetry. So that's a little bit of the case for using TheraSphere in case you are challenged about costs and things. But that's myself. And I don't know what you want to do here, Neil. Hand over straight to Pete, or do you want to take any questions?
If there are any questions, please do feel free. But other than that, I'm very happy to hand over to Dr. Littler now.
Right. Can you see that?
Yes, thank you.
Brilliant. Feel free to interrupt. I'm afraid this is 89 slides, so hopefully it won't become death by PowerPoint. But yeah, feel free to interrupt on the chat, and then Matilda or Neil can ask the questions as we go to break it up a little bit. I'm Pete Littler. I'm an interventional radiologist from the Freeman Hospital up in Newcastle in the northeast of England. I've been doing SIRT for a good while now, probably since 2012, I would say. And we've noticed numbers have really racked up recently as we've sort of done better and better with the patients. And a lot of that's linked to the dosimetry, that we've found the numbers have increased and increased over time. And I think that's because the people in the MDT, the referrers, see the good responses that the patients are getting. And they're more keen to, the MDT can spot the right cases to do, and they come through. So talking numbers, I think for, quite a few years, I think we did about 30 patients a year. And then last year, we were up to 100 patients in the year, and it shows no signs of stopping. And we've noticed a decrease in the number of cases that we do as well, not quite in step with that, but certainly a bit of a drop in the TACE numbers, and the SIRT numbers are really increasing massively. Right, so I'm focusing on HCC really. We use SIRT for some colorectals and also some neuroendocrine patients. But HCC, I think, is our biggest group by far, patients that we treat. SIRT tends to work really well, I think, in hypervascular tumors. So the very vascularized tumors suck up the treatment nicely and get good responses. So rowing back a few years, this is the BCLC guidance, which is a sort of international thing that I'm sure many of you are aware of, that guides treatment of HCC patients, and it provides a strategy really for across various stages. So you've got the sort of early stages, where you've got smaller tumors within transplant criteria, and you're looking for sort of curative therapy. You've got the intermediate stages, which is more sort of palliative, and advanced stages as well. So SIRT didn't make an appearance on this at all, this BCLC guideline. And that's really due to a lack of the positive phase 3 trials that were done sort of between, say, 2015, 2017, that sort of time. And they were done really without the personalized dosimetry that we have these days. So they're done on very basic dosimetry based on body surface area that didn't really take into account the size of the liver or the sort of size of a number of tumors to treat. So the tumors would get a very variable dose and the background livers would get very variable doses, so the outcomes were sort of all over the place. So really, despite the lack of positive phase 3 trials, we really see a use for it in the earlier stages. So that can be as a radiation segmentectomy. So treating smaller lesions in patients who aren't suitable for resection, transplantation, or ablation. We also use it in patients who would otherwise be suitable for TACE. So our NICE guidance that came out a couple of years ago says that patients should not be suitable, not be treated with SIRT who are good for TACE. So if patients aren't good for TACE, and we typically say this is sort of 6 centimeter plus size tumors, don't do well with TACE, and then they will go on for SIRT. And we see a definite role for SIRT in this group, and can treat tumors up to 20 centimeters in size, and the treatments tend to be really nicely tolerated. And also in the sort of more advanced stages in patients with either portal vein invasion or perhaps less fit. So SIRT, as I've alluded to, has changed an awful lot over the time I've been doing it, the last sort of 13 or so years. It used to be very much basic dosimetry. We used to see the left-hand picture. We used to coil all the vessels to really skeletalize the liver and give a whole liver treatment. Nowadays, it's very much more, as Neil was saying, very much more a targeted, tailored procedure where we look at the volumes treated of the liver. We try to make it as selective as possible, so we hit the least background liver that we can. And then we can move on to the dosimetry, which is really the holy grail, which is the key, I think, to the good outcomes that we see these days, is that we can work out the dose to the tumor and the dose to the background liver and reach the various thresholds needed. So personalized dosimetry, you can either do a single compartment model where you're just treating an amount of tissue with a dose, or you can use multi-compartment where you've got the volume of tissue that you're going to treat, and you can reach thresholds within the tumor and also thresholds within the background liver to protect it, which is very important in patients with cirrhosis. And you can reach those thresholds to kill the tumor, and also obviously looking out for the background liver. So just to show you a sort of classical case of dosimetry, this is a sort of typical case that we might get. So patient's performance status sort of 1 to 2, not the fittest. Big tumor on the right lobe of the liver, which you can see there. Not fit for resection. We do the pre-SIRT, and here we can see that we did an injection point to the perfused sort of right lobe of the liver. We inject a tracer, technetium MAA. And we've got a cone beam CT, which I think is really mandatory for doing all this work. So I think all of your IR centers are likely to have cone beam CT, because you need to be able to get the volumes that you're going to treat. And then we do the MAA injection, and then you can see the uptake within the tumor and the perfused volume, and no uptake within the non-treated area or the non-targeted area. So then we can move to the simplicity system, which Neil was showing before, where you can see really, we've picked a terrible color here, but this little outline, I don't know if you can see my arrow, my cursor, but anyway, there's a sort of very light blue line, which is the perfused volume, which is the right lobe. And then you can see the tumor outlined in yellow there. And then we've got our perfused volume. And then we've got the activity we want the tumor to get. So the tumor is going to get nearly 250 gray. And this really, over time, as more and more papers have been published, the dose thresholds have gradually increased. So nowadays, we'd probably go for 331 gray to the tumor. And also, it'll tell you what the perfused normal liver got, which in this case is 30. So this is one of those phase 3 trials I was telling you about earlier, the SARA trial, and it showed comparing SIRT to sorafenib, showed no improved overall survival of SIRT patients versus patients who received sorafenib. However, the treatment was better tolerated in the SIRT group. However, post hoc analysis was carried out of that data, which gave a hint really that personalized dosing could have improved outcomes for patients. In that over 100 gray to the tumor, you saw better response rates than those who got less than 100 gray to the tumor. And then moving on to the TheraSphere study, where they took quite an advanced group actually. So 7+ centimeters in size tumors, portal vein tumor invasion in over 60% of the patients. And they randomized into standardized dosimetry or personalized dosimetry, and found if you use personalized dosimetry and got a tumor dose of over 205 gray, then you more than doubled overall survival. This is a really useful paper, and it's the sort of dose guidelines for HCC treatments. I think there's recently been a similar guidance published in the same journal, I think, looking at dose guidance for other tumor types like colorectals, neuroendocrine, etc. And this is a really useful document, and we still refer to it today. And it gives you various strategies and the sort of dose guidance for each strategy for treating HCC. And I'll run through some of those now. So there's radiation segmentectomy, where you're treating sort of smaller tumors in a small, up to 2 segments of liver. And you can use single compartment dosimetry. So you just give the whole perfused volume 400 gray, and you get a sort of curative therapy. So it's really an alternative to ablation and that sort of thing. And we've used it in some patients, and it seems to work, seems to be extremely effective. Dose targets, as I said earlier, have changed over time with this. Initially, they looked at the tumor's got 190 gray with a radiation segmentectomy, and showed greater complete pathological necrosis if you got sort of 190 gray plus to the tumor. And then we move on to the legacy study, where they treated very small tumors. I think median size was like 2.6 centimeters with 400 gray. They found it a really well tolerated procedure, and the outcomes were similar to the curative therapies with overall survival. And it was really this legacy study, even though it was a retrospective study, that got radioembolization onto the BCLC for the first time. And that was published, I think, in 2022 as an option really in these earlier stage curative type treatments in patients sort of unsuitable for resection and ablation. And they got to this 400 gray threshold by post hoc analysis of the resected lesions in the patients with the legacy study. So those where the tumors got over 400 gray, 100% of them achieved complete pathological necrosis, and that was used to sort of inform that threshold. So in the UK, we work with the NHS commissioning, following on from the NICE guidance, and our use of radiation segmentectomy is a little bit limited by that, in that patients who are unsuitable for curative therapies with ablation or resection or transplantation would go via the process of treatment stage migration along the BCLC algorithm and then get TACE. And sometimes we'll be able to TACE them and downstage them to ablation quite frequently. But some patients aren't good for TACE. And it's really, as I sort of mentioned earlier, if you've got a lesion that's 6+ centimeters in size, they do more poorly with TACE. And if you've got things like previous biliary intervention, say branch tumor thrombus or bland portal vein thrombus, then you may be more concerned using TACE because you might be more at risk of getting sort of liver abscesses and what have you. So you might then be able to treat those patients with radiation segmentectomy. And I think the most common reason for us being able to do a radiation segmentectomy is the lesion being on the big side for TACE. So 6 centimeters, we've kind of shuffled it down to 5 centimeters now. So 5+ centimeter solitary lesion will go for SIRT rather than TACE. So just to show you a couple of radiation segmentectomy cases. So this is a 73-year-old patient with alcohol-related liver disease, and he's got 2 cancers. So he's got a lung cancer and he's got a 35 millimeter segment 7 biopsy proven HCC without cirrhosis, just mild steatosis. And he's got sort of non-obstructive CBD stones. And really, we want, he's got an AFP of 122, and he's quite fit. And really want a holding treatment to enable his lung cancer to be resected. And then we can look at potentially resecting or treating his liver tumor afterwards, potentially resecting it. As it's 35 millimeters, we wouldn't typically ablate that above 30 millimeters. So we would look to either TACE or SIRT. And in this case, because of the non-obstructive CBD stones, we were able to justify doing a SIRT treatment. So we did a radiation segmentectomy as a bridging therapy, initially to allow time for the lung to be resected, but then also potentially to come back and do hepatic resection to treat this lesion. So there's the tumor, and we were able to do a very selective, almost a bit like a TACE in that it's super selective treatment of only a very small area of liver. And you can see the tumor lighting up nicely there. This was the fraction of the liver was about 13% of the whole liver. And you can see really nice uptake within the tumor. We're able to give just under 400 gray to the perfused volume. And you can see this is the Bremsstrahl lung SPECT CT post-SIRT. You can see the tumors taking it up so nicely. It's just hoovered it all up with a small area of normal tissue that's also exposed. So then we did that treatment. Patient, it tends to be very well tolerated. Patients post-SIRT just tend to get a bit of fatigue after a few weeks, but very little else. So underwent their left upper lobectomy. And then CT 3 months post-SIRT, you can see the tumors essentially gone. You see a bit of enhancement on the arterial phase with the treated parenchyma, and we often see that. And I think it's just a sort of local fibrosis where you've had this high dose of radiation. And then at 12 months, so we've got a sustained complete response. AFP's gone from 122 to 4. You're getting sort of indrawing of the capsule there, where you get atrophying of this area. And there's no signs of recurrence, and really there's no driver now. I don't think to resect that, and we're just watching the patient. So second radiation segmentectomy case, 73-year-old female, alcohol-related cirrhosis, had chronic bland portal venous thrombosis, sort of non-occlusive. You can see the arrows there. And on surveillance, she had a 35 millimeter segment 7 HCC, and her AFP was really ramping up. So it was while the patient was being sort of assessed and what have you, the AFP went from 10,000 to 19,000 in no time at all. No extrahepatic disease. So here is the tumor enhancing and washing out. We elected to go for SIRT here rather than TACE because of the bland portal venous thrombosis. And you can see very small, nice little area that we're treating, very selective again. So this is the sort of ideal radiation segmentectomy type situation. We gave 410 gray to the perfused tissue. And you can see again the tumor really taking it up beautifully. And we've only treated a very small area of liver. And then we've got a few months later, we've got a scan showing the tumor is essentially gone, and the AFP's dropped from nearly 20,000 to 18. And that's sustained on follow-up. So that's radiation segmentectomy. Now moving on to radiation lobectomy. Now, we can treat pretty big tumors, and quite commonly treat them tumors more than 10 centimeters in size. And you can potentially get patients who would be able to have a resection, but their left lateral lobe that would be left behind is too small. So their FLR, we call it, is too small. And so another advantage that we've found quite useful in SIRT is that if you treat the tumor and also treat some of the perfused background liver on the right lobe, you can actually grow the FLR, grow the left. It's a stimulus to grow the left lobe to get them to resection. So you have a big tumor, it's unresectable. They would do terribly with TACE because it's a huge lesion. Medical therapy wouldn't really offer them a long-term option. And you can actually downstage them and facilitate resection by doing SIRT. You can also use these treatments to sort of in patients with cirrhosis that are never going to get to an operation. We have lots of patients like that as a nice palliative treatment as well. That tends to be well tolerated. Sorry, we've got an extremely loud fly just flown in here. Don't know if you can hear that. Right, so radiation lobectomy. So we treat Child-Pugh A patients, and we can grow that left side. And here's a case that was one of the first ones that I did with TheraSphere, actually, back in 2015. And so it was a 56-year-old man who had a bit of asthma and went into hospital with breathlessness. And they did a CTPA liver CT, sorry, CTPA chest CT to look for a pulmonary embolism. And on the very bottom slices, they found this massive tumor that was completely incidental. He didn't have any signs of cirrhosis, but you can see the tumor here outlined in red, and you can see on the right-hand picture, this would be the FLR, the future liver eminence. If you chop this away, this would be what you were left with. So obviously that's going to be too small to sustain life. And you can see this tumor is also beginning to press on the bile ducts, seeing dilated bile ducts in that left lateral there. So at the time, we were doing some SIRTs, but not lots and lots. And we looked at his options. So he could have had sorafenib, which would have given him, say, a 12-month survival, probably, there or thereabouts. We could look at TACE, which would bite a few holes in this, but wouldn't achieve much of an outcome. So we didn't really feel we had a lot to lose. So we went and treated with SIRT to the right lobe of the liver. And this was sort of before personalized dosimetry, but I've gone back and looked at it. We treated, 3 liters of liver, huge amount. We spared this left lateral, so this left lateral didn't get anything. And in retrospect, I've gone back and found the tumor got 150 gray, and the perfused background liver got 12.5 gray, so very little. And we were limited by the lung shunt dose to that. Quite a few months passed, probably best part of a year. And then we saw that the tumor had actually shrunk right down. The same volume was now had halved, so from 3,000 or 3 liters to 1.5 liters. And the tumor had shriveled up markedly, but was still enhancing. So we did a second treatment to this right lobe, and the tumor, in retrospect, when I've gone back and worked it out, got a 350 gray to the tumor, and the background liver now got 82 gray, which was more of a sort of impetus for the left lateral to grow. So because we got a slightly larger dose to the background liver, that prompted growth of the left lateral, which we didn't see with the first treatment. And so then you can see this is December 2014 when he first came to us with this big tumor. The tumor volume was nearly 1,700 mils. And post-second treatment, the tumor's down to 63 mils. And the left lateral had grown hugely. So you can see it there, and then you can see it here. And now it passes the threshold to enable the patient to go for curative resection, something that wouldn't have been possible with other treatments. This is pictures at surgery. You can see a juicy left lateral, and the right side was taken away with the remnant of the tumor, which is apparently the size of a broad bean. I don't know if you have many broad beans in Sweden, but very small. And then post-resection, he's had a durable cure, basically. So this is out to July 22. I've followed it. I haven't updated this slide. I must do that. But I've been reporting his follow-up imaging and right out to 2025. Excuse me, 2025, he's still disease-free. So we've looked at radiation segmentectomy. We've looked at lobectomy with the potential for downstaging to resection and growing the FLR. And this is more looking at sort of unilobar disease where you get either, multiple or one or more lesions, more in the palliative type setting, or bilobar treatments for HCC. And really, we do these quite commonly. If they've got multiple lesions, and particularly bilobar, they go for medical therapy. We don't treat those with SIRT. We worry about treating someone with cirrhosis when you're treating their whole liver. With SIRT, we are worried about radiation-induced liver disease, although I know it is possible, but you've got to be very careful. So we avoid those treatments, and I think that's probably a good rule, particularly if you're getting started, is to focus on unilobar disease, and you can do personalized dosimetry and be really, really safe and effective. So I say don't treat bilobar disease for HCC, that is, but there are situations where you can use your different tools at your disposal to tackle patients. So here's a patient with effectively bilobar disease. So he's got bulky disease on the right side of the liver. He's got a tiny HCC just next to the left lateral, just in the left lateral rather, next to the left hepatic vein. So he's a sort of guy with comorbidities, and not the fittest. But we elected to treat the left lobe, just this tiny thing, with ablation. So we ablated this, and then we went on to do a SIRT to the right lobe. So there was his ablation in August 2017, and then he had this SIRT to the right lobe, and you can see great uptake within the tumor there. And then years later, he's got a durable complete response, essentially. So complete response to this ablation, and he's just got sort of calcified husk remaining of where the tumor was on the right. And because of his age and comorbidity, he hasn't gone to resection, but it's just been effectively palliated with this.
Hi, Pete. I see we have a question here if you're
Oh, lovely.
yeah. So Andrew Vong, do you want to say it yourself, or should I just read it here?
Sorry, yeah. Do you want to read it? Yeah.
So how would you convince your surgeon to refer this patient for SIRT instead of PVE?
Right. Yeah, that's a good question. Yeah, so I think so. PV. So we'd say do double vein embolization, and we do that for colorectal or sort of cholangio. We'll treat one side with double vein embolization to grow the other over a few weeks. With HCC, we prefer, because often they've got some level of background liver disease, some description. We know that they respond really nicely to SIRT. That we prefer to do this right lobar. It's typically right lobar treatment with SIRT. I think SIRT doesn't do brilliantly for colorectal in the same way as it does for HCC, and obviously you can't SIRT cholangiocarcinoma, a ductal cholangiocarcinoma. So you haven't really got an effective option, I don't think, with SIRT treating those etiologies, which we typically do the double vein embolization for. But I do think HCC you can do really, really well. You get a test of time, and you grow the FLR slowly over months. That's your test of time. And while it's happening, you're actually treating the tumor, and it can pull away from vital structures to make the surgery potentially easier. So I think that's our approach anyway. So I hope that's of some help. It is really effective. I think that's the key thing, and I think because it offers an effective treatment for HCC, you get the test of time, and you get to grow the FLR nicely, pull away from structures, and so hopefully making surgery more straightforward.
Super. I see here. Thanks for your response.
All right, thanks.
I think that answers his question.
Okay, so we've gone through the various strategies for sort of palliative, lobectomy, potentially getting downstage to resection, and also radiation segmentectomy as like an alternative curative option. But you can also treat HCC with macrovascular invasion. But I think the key thing with this is that when you do your pre-SIRT and your MAA study, then you're looking to get good uptake within the tumor thrombus. I think if you don't get good uptake within the tumor thrombus, then it's not going to be an effective treatment, and you should go straight for medical therapy instead. So that's the key sort of message from that. And this is a nice case, courtesy of Etienne Garin, who actually wrote the TheraSphere paper. But it's such a nice case that he let me use. You've got this horrible sort of infiltrative type HCC, and you got this tumor thrombus there extending into the portal vein towards the main portal vein there. And you've got, this is the pre-SIRT, and you've got really, really nice uptake within the tumor thrombus. And with that, you can dose it accordingly. Just treat it as if it was, well, as it is, it's as part of the tumor. And then you can get retraction of this tumor thrombus and reduction in size of the tumor, and potentially in this case got the patient to a resection with an overall survival of 49 months, which is pretty impressive considering where they started out. So I've kind of alluded to this already, that NICE, the National Institute of Health and Care Excellence, which we need really to review technologies and treatments, and then they give their verdict. And then once they've given a positive verdict in England, then the NHS will commission it for centres. So it was a big thing when NICE gave SIRT for HCC the thumbs up, as it were. And NICE allows us to treat patients with good liver function, so Child-Pugh A, when conventional transarterial therapies are inappropriate, so TACE, which I've kind of alluded to before, and allowed an MDT decision, so it's personalizing the treatment options for that patient. We are a transplant and tertiary HPB centre. We've been treating SIRT patients with SIRT for all sorts of things for well over 10 years. And in our MDT now, we actively seek unresectable patients with large unilobar HCCs, and really down to about, solitary HCCs, sort of 5 centimeters plus, we'll go for SIRT straight off. Obviously, good liver function, performance status 0 to 2. As I've mentioned before, if they're cirrhotic, try to avoid whole liver treatments, and non-cirrhotics are the patients where we have the greatest potential to get them to curative resection. So we published a sort of retrospective audit of 51 consecutive patients. And we found our etiology of our HCCs. We had an awful lot of NAFLD, so fatty liver disease patients, and 39% of all of our patients had no established cirrhosis. So there's real potential in quite a few of our patients to downstage them to facilitate curative resection. So we looked at a few highlights really from the groups that we looked at. And so one group was sort of solitary large tumors. So we had 21 patients, 7+ centimeters in size, HCCs, and our median overall survival was over 40 months in that group. And we had a 25% resection rate, and all of whom remain alive. So that was quite nice that in those patients who would do badly with TACE, that we got a median overall survival, right up there with the sort of best TACE outcomes. The second group we looked at, some of these numbers are small, so you can't draw massive conclusions from them. But we found that at the NDT, if you're between certain TACE and you do TACE, and you do, you TACE them, and then they progress, then they don't do well with SIRT particularly. So in median overall survival of 14.8 months in that cohort. So that sort of, we felt, supported our decision to actively choose SIRT as the first line treatment, rather than try the thing that you've done for years first for a bit and then jump ship to SIRT later. So we actively choose SIRT as the first option. We did well in patients with PVT, but again, you're looking for good uptake within the tumor thrombus. And the patients who did terribly weren't suitable for sorafenib. Some of them they were a very advanced group, metastases and all sorts, and they weren't suitable for anything effectively. So it's not a panacea. In our summary, we've just included where we think that you could incorporate SIRT potentially into the treatment algorithm for our patients. We have our MDT set up, so we have a weekly HPB MDT with everybody there, and those unilobar set 5+ centimeter HCCs go straight for SIRT. Some small lesions we think are radiation segmentectomy, maybe if they're not suitable for TACE for whatever reason. And then we have a weekly SIRT MDT where we just run through, are they definitely suitable? Do they meet the various criteria? And do you need any more imaging or anything like that? And then we list them straight from there. So just to show you, if we've got time, just a few more cases. Fibrolamellar HCC. So these tend to be resected. There's very little evidence for any sort of chemotherapy treatments, any local regional therapy treatments for these cases. They tend to get resected. But when you have something, you have a tumor like this one, I don't think you can actually see my pen here. Oh, here you go, laser pointer. Right. So you got this huge one there in the middle, right in the middle of the liver, right where the clockwork is. It's sort of abutting, possibly invading the IVC. This was post TACE because we didn't really have any evidence to support anything in this. Obviously non-resectable. We did a couple of TACEs, and this is post a couple of TACEs, so you can just see small areas of necrosis, but really it hasn't made an impact. And then we did a SIRT, and the tumor took it up beautifully. And you can see we actually published this as a case report, an AFP of over 50,000 and a tumor, you see a solid tumor of 9.5 centimeters. And a few months later, 7 months later, the tumor's just down to a little sort of husk, 38 millimeters. And with that, opened up opportunities for resection, even though it was in a horrible place and stuck onto the IVC. We were able to go ahead and do a resection and chop out a bit of IVC and replace it with a Dacron graft. But there's the tumor in the surgeon's hands there, and they had a durable cure post that. There you go, 5-year follow-up. Here's a patient, 76-year-old hemochromatosis, who's got this largish tumor here and a couple of little ones, HCCs, sort of up in sort of segment 8, 4A, good liver function. We had a look, and here's the main tumor, and here's the sort of little cluster below. So we planned for a SIRT, and you can see that we were giving over 300 to the tumor there. The background liver was getting 80, the perfused background liver. But there was a tiny little edge there that wasn't getting SIRT, and to treat that adequately, you would need to, I don't know if I've gone into this, no. So to treat this with SIRT, you would risk treating all of this left lobe because it was some tiny little branch that you could probably get the smallest microcatheter into. So what we did is just did a little Lumi TACE at the same time as the SIRT, just to treat that tiny margin there, rather than risk giving all of this SIRT pointlessly. And you can see there the main tumor took up the SIRT beautifully. There's the Lumi TACE along the edge there. You can see that there. And then 6 months later, obviously sustained complete response. This is what you see, that you see improvement in appearances over time. We don't tend to follow up people at 1 month because you're not really seeing much in the way of a response. You should start to see a response at 3 months, and at 6 months, you can see a further improvement in the response. And we just tend to keep following people out, as Neil was saying earlier. So we're obviously looking, does it look sort of slightly better or the same or better? Even if there looks to be residual disease there, we follow them out for a while before deciding on whether they need any further treatment or not. Just to show you the sort of size tumors that you can treat. So this was a 23 centimeter tumor in a 50-year-old non-cirrhotic patient. And we treated with a 14 gig of TheraSpheres to this because it replaced the entire right lobe. So the actual dose was higher than we could get through a catheter in a single dose. So we had to give 2 sequential doses from the same position. And the patient tolerated it really well. I think 1 or 2 more cases. I don't actually know how many more. Sorry about this. Here you go. So a right lobe HCC, big HCC, moderately differentiated, non-cirrhotic Child-Pugh A, 75-year-old. We treated with SIRT via the replaced right hepatic artery. You can see that uptake there. So we're getting the volume, so we can do the dosing. And from the left, there was really lots and lots of different branches going to one edge. And amongst this, I think this one is the left lateral, which we didn't want to expose to SIRT. So we elected to do TACE via sort of about 3 small branches rather than sort of do sort of 3 tiny doses of SIRT. And we were able to do a sort of hybrid type procedure. So we treated with, this is a sort of yin yang appearance where we're getting SIRT to most of the tumor and just some LumiTACE to the bit that was supplied from these multiple tiny branches. And you can see this is the pre-SIRT CT, and then 8 months post, you can see the bit that was TACEd, the bit that was SIRTed, and then and you can also see growth in the left lateral to enable the patient to get to a curative resection. Penultimate case, there we go. So just to show you, rather than just showing lots of cases that get to resection, just want to show you more of a sort of palliative type case. So we've got a 68-year-old with PSC cirrhosis, UC, had previous variceal bleeds, Child-Pugh A, so I did have good liver function, but had a very sort of small, shrunken looking liver with an 8 centimeter HCC, which is a bit difficult to spot, but it's here in the top of the sort of the right dome, and didn't really have much in the way of a left side of the liver. So we were able to do quite a selective SIRT to that, which you can see really nice uptake within the tumor, and we sort of were able to spare lots of the sort of inferior aspect of the right lobe. So at 2 years, what you're left with is a tiny sort of calcified husk, and the patient is still good liver function, and has had a durable palliative treatment, really. So final case, just to show some of the issues you can come across. Sometimes the case can get quite complicated. So you've got this patient with several HCCs. So there's a big one here on the right lobe, there's a small one on the left lateral, and there's a small one at the posterior in segment 6 lower down. And what we did is we were looking to potentially offer an ablation to this small one, but in the end we did a TACE to that small one, potentially to shrink it down for future ablation. And we wanted to do a SIRT to this right lobe of the liver. So this is the right hepatic artery where we planned to treat from, to keep it simple. And we injected our MAA from there to treat those 2 big ones. But what we found is when we came to look at the SPECT CT, we found massive uptake within the gallbladder. So the cystic artery, which was here, took up a lot of the MAA. So we didn't feel it was going to be safe to carry on with the treatment from that position. So occasionally you have to bring patients back for a second pre-SIRT, which is what we did in this case. So there's the cystic artery, and we treated with SIRT from here, and we did a little TACE from there because it was a tiny vessel to the small inferior lesion, and we were a bit concerned with doing a SIRT from here into such a tiny volume just directly opposite the cystic artery, and we did another SIRT from this position. So we were able to do all 3 injections in the same treatment sitting. It doesn't take too long once you've made the plan. So we had our cone beam CTs from each of the planned injection points, and then we did our dosimetry to plan the 2 doses that we wanted to give to make sure we're getting good tumor thresholds and safe doses for the background liver. And also we had an area that was missing from the SIRT planning, which was going to be TACEd. Actually, I haven't got the follow-up imaging. Anyway, patient did well with that, and we managed to not hit the gallbladder at all. Because what you don't want to do, I guess, is do a palliative type treatment in someone with multifocal HCC and then make their lives miserable with horrible cholecystitis afterwards. You can get away with low doses of SIRT to the gallbladder, but that's the sort of appearance that you don't want to see, because that gallbladder is going to get an awful lot, and the patient's likely to run into trouble. So, just in summary, I think it's got SIRT we find really useful in treating HCCs. I think hypervascular tumors do really well with SIRT. In England, we've been commissioned to use SIRT to treat these patients, and I think it works really well for unilobar bulky lesions. And you can also treat smaller lesions with radiation segmentectomy, which we've found works beautifully. It's an evolving technique. Cone beam CT in your IR labs, I think, is crucial because you need to do an injection point from you need to do a cone beam CT angiogram from each of your injection points to enable you to plan properly. And personalized dosimetry has been a real game changer and is definitely associated with better outcomes. For example, we had very few complete responses in our first cohort of patients that we published on, and now we have a 25% complete response rate, and also we've noted the median overall survival of the whole cohort when we've reaudited it recently has increased from sort of 20 months all comers to 30 months all comers, and we're just in the process of publishing that data. And I think that's related to improved patient selection and personalized dosimetry. I think personalized dosimetry has been the most important thing in getting those complete responses and improved overall survivals. So thanks very much. Sorry, that's been a lot of slides and chat, but I hope that was of some interest to you. And if you've got any questions, that'd be great.
Thanks very much, Dr. Littler. Massively appreciated. If there are any questions, feel free to come off mute or pop them in the chat, but there aren't any active at the minute. So just as a finisher from our point, thank you again for your attendance. Thank you to those who do watch the recording as we move forward. This was meant really as a bit of a taster for what's possible with SIRT and the patient selection we think about versus what you might be doing today in your hospital. We, as TheraSphere, as a product, are aiming to go live once we complete MDR in Sweden and at the back end of this year, Q4, maybe pushing into Q1. So this was meant, as I say, as a taster and a discussion starting point from it. I'm very aware from starting multiple sites around Europe now that from initial discussion through the first case can be 6 months to a year very easily. So please feel free to reach out to Osa and Matilda. You've got Rob's email from this as well. Any of your local account managers or points of contact. And ideally, I'm sure I speak for Peter and myself, we'd love a trip out to Sweden to visit a few hospitals and help doctor a few cases.
Absolutely.
Brilliant. Well, thank you very much, Dr. Littler, for your time. Thank you, Rob, as well. If anybody has any other queries, as I say, please do feel free to reach out, but we shall end it there, if that's okay, Matilda. That
was really good. Thank you so much for the time. Really appreciate it all.
And thank yous in the chat as well, Pete. Thank you, guys. Have a great evening. I'll speak to you soon.
Thanks a lot. Bye. Bye, everyone.
Bye.
Bye-bye.